Hello, I welcome you all for this web conference for EUS, and good evening to all participants from Asia, East Asia, Australia. Good afternoon to those who are from Middle East, Europe, and good morning for those joining from America. So today we have our distinguished faculty from Singapore and Thailand. Dr. Christopher Khor is chairing the session, and Dr. Pradermchai and Dr. Damien from Singapore will be speakers for our lectures in EUS. And we want to thank all the organizers, especially the Pentex Singapore, Apex, and Pentex Pakistan for supporting us and for organizing this event. And I would like to start this session, first of all, with the introductory remarks from the session chair, Dr. Christopher Khor, who is a senior consultant, Department of Gastroenterology and Hepatology, Singapore General Hospital, and also adjunct associate professor, Duke and US Medical School. He is also the vice president of JITAP and EUS TAP faculty as well. So, Dr. Chris, your introductory remarks.
Thank you very much, Adeel. It's a real pleasure. Adeel and I go back some way because we had the pleasure of him working with us for 5 years a while back, and you know, he was a real star. And so it's a real pleasure to be doing this together with him and with two very good friends and colleagues here. So we have a nice program planned for you. You know, many thanks to Pentex Medical in Pakistan and in India for facilitating this. And these are two very pertinent topics which are important to EUS practitioners and wherever you are in the world. So without further ado, I'm going to hand you back to Adeel to introduce the first speaker.
Yeah, thank you, Dr. Chris. So our first speaker is Dr. Damien Tan. He is a senior consultant in the Department of Gastroenterology and Hepatology. He's also the director of endoscopy over there and director of fellowship program as well at Singapore General Hospital, Duke and US Medical School, and one of my trainers as well. And I'll hand over for your very interesting and for your talk on pancreatic cystic lesions. Hope everyone will enjoy. Dr. Damien.
Okay. Hi, good evening, everybody, and good afternoon and good morning to those from different parts of the world. So today, it's a great pleasure to be invited by Pentex and by Adeel, and my talk will be about the role of EUS in pancreatic cystic lesions. These are my disclosures. As an overview, I'll talk about the background, the diagnosis, which is the most important, and treatment. Treatment was because of some questions that were raised in the questions, so I'll try to cover a bit of that, hopefully. All right, so why are cysts important? Because we know that cysts actually have pre-malignant potential. And basically, we know that the pancreatic cancer goes through different pathways, and the cystic pathways forms about 20% of them. So this is what the Japanese has shown us previously, that the penin pathway is the ductal pathway, about 70 to 80%, whereas the cystic pathway towards cancer forms about 20 to 30%. So what's the problem? The problem arises is because we cannot differentiate between the mucinous and non-mucinous cysts easily, because the mucinous cysts are the ones that will go down the cystic pathway towards the adenocarcinoma. And if you look at a pancreas cyst, they could be any of these. These are the more common ones, and we'll try to briefly cover about how we go through them. So how do we differentiate between the three groups, benign, pre-malignant, or malignant? And what do we do with the pre-malignant group, which is what a lot of us face once we start diagnosing them with IPMN or MCN. So before we go down there, we need to understand a bit about the history of why these cysts are not just operated on just after we find them. And I think Bill Brugge and Fernando Castillo from the Mass Gen group showed nicely that if you have an incidental cyst in their large cohort series, about 30% of them will be benign if all of them go for surgery. So we know that sending everyone with an incidental cyst, 30% of them will be benign. That's if they're asymptomatic. And same thing from my hospital, they studied a large group of patients, and it's a 15-year study. And they actually look at the incidental cysts. And similarly, they found that up to 53% of them were totally benign, and they had undergone surgeries include Whipple's. And this is no joke because Whipple has a significant mortality risk. So therefore, it now comes down to us how we help our surgeons to classify cysts. The Europeans have talked about how they classify cysts in their most recent guidelines, and they divide them into epithelial versus non-epithelial. And epithelial divided into neoplastic and non-neoplastic. Likewise, for non-epithelial, they divide the neoplastic and non-neoplastic. There are so many cysts, but I think the ones in the red box are the ones we deal to on a day-to-day basis. These are the most common. And occasionally, we do have the blue ones, which are the cystic neuroendocrine tumors and the solid pseudopapillary neoplasms. The rest of the cysts are pretty uncommon, and you probably won't need to discuss too much about it. Likewise, Americans have come out in their own guidelines by Grace Alter and Anne Marie recently. And the same thing, they talk about cysts, dividing them to non-neoplastic as well as neoplastic, but they didn't subdivide them by the epithelial cell lining. So I like to think of cysts in a very more simple way. This is from an old paper, and they talk about no cyst lining or epithelial lining and those with the epithelial lining. And to me, it's very important that we actually diagnose them so that we can discharge them. Usually things like pseudocysts or serous cysts, you want to discharge them. And for those patients who are what we call pre-malignant, we usually look at MCN and IPMN, and these are the ones that we need to survey. And of course, upfront, if they are malignant, these are the ones that you want to operate straight away. So I try to box my cysts into 3 boxes, in which you will then tell me how best to manage them. And I'll go through slowly how I try to solve these problems. Okay, so how do we differentiate? Okay, so this is from a paper which is World Journal of Gastro that talks about looking at different factors between the more common cysts. If you use gender, you find that for females, we tend to think more of MCN, SCN or serous cysts, or the SPN. If you think based on age, if they are younger people in their 30s, more likely to be MCN or more likely to be a SPN. All right, so if you're a female, just remember most likely MCN, SPN, and like this, if they're young, MCN and SPN. And for appearance-wise, based on CT or MR, it's quite hard to differentiate other than looking at this central fibrosis or microcystic appearance for serous cysts. But for all the rest of the cysts, if you don't have any ductal communication, you can't really differentiate very well. So sometimes we do get communication, then you can say upfront, yes, it's most likely IPMN, or it may still be a pseudocyst. For the rest, they don't have ductal communication. And same thing for classification, you think of SCN or MCN. And over here below is what we look out for when we start to do EUS. And I think that so far, what people have really found to be helpful is mainly the cyst fluid C8 is found to be very low. It's more likely SCN. The rest is actually a lot of overlap, which I'll show you later. And likewise, looking at the viscosity, I've had very viscous serous cysts also at times and very dilute mucinous cysts at times. So it's not very clear cut all the time. So EUS is important because it provides the ability to image the cysts, and FNA, the cyst fluid, gives us more information. And it's all started also from the same group by Rudy. They looked at the CEA. They actually had 341 patients, and when they analyzed just using EUS imaging alone, 51% of them could only be diagnosed by EUS. When you add on it was 59, but add on CA, it went up to 79%. And they found that CA alone was actually the most useful test to differentiate between mucinous and non-mucinous. If you look over here, you can see if your non-mucinous is serous, it's very low. Everything else, it could be anything from malignant to benign or to inflammatory. So all we can say very low, most likely you're serous. Of course, in the rare instances, there are some benign and some inflammatory, we still have low CEA. And this is the cutoff, the magic number that people always talk about, 192. But to me, I think I look at values, anything less than 5 or less than 10 has to be most likely a serous. If you are 190, I can't say for sure you are serous still. So because of that, I think people have decided to try to look at other things, and that's what we're going to kind of look at later. So back to guidelines. At the time, they didn't have advanced things like genetics and to help us. So we actually use guidelines, and these are more the later guidelines that I'm going to talk about. To me, I look at guidelines in 2 types. One is what you call the all-comer cysts, and the other one is the IPMN. All-comer cysts include the AGA, European, and ACG, where they talk about cysts in general when they first present. And whereas in the IPN guidelines, they are very clear that only if you diagnose IPMN, then you follow these guidelines, or if you're MCN, then you follow these guidelines. So going through the all-comers guidelines, this is the one that comes out from AGA, and you can see it's actually quite a straightforward guideline. You just see a cyst, and once you have what you call 2 or more positive features on MRI, send for EUS-FNA. If you have concerning cytology, you operate. If there's none, you put them on surveillance. And a lot of people who do pancreatology are a little bit worried about these guidelines because this guidelines has a box that says stop surveillance. We all know that if you have a pre-malignant cyst like a IPMN, it's about 5% at 5 years, 10% at 10 years, 50% at 15 years. We know that stopping surveillance, after a 5-year surveillance program, you may still miss some of them, which eventually will turn cancerous further down the road. But of course, in the defense of these authors, when they presented at DW, they actually looked at all the available evidence and they felt that this was best for community practice. This came out from the ACG and is a bit more busy, but also it's the same. It talks about all comers and they don't differentiate between whether you're IPMN or not. But the main thing is that they want to know based on symptoms. You have pancreatitis, straight away you think of it's likely to be a pseudocyst and then follow clinically. But of course, if you worry that it's a mucinosis precipitating the pancreatitis, then you do EUS-FNA. And likewise, once you have symptoms of jaundice or mass, straight away to refer to a multidisciplinary group for surgery or EUS-FNA. But if you're none of the above, you're not sure whether it's serous, you don't know whether it's IPMN, that's when you start to follow their criteria about looking at duct diameter, cyst size, or change in main duct caliber. And likewise, anything that looks worrisome, they will actually refer for FNA. If not, they will actually put them on the surveillance program. And over here, the surveillance program, it's more or less similar to the IPMN surveillance program that was previous. That I'll show you later. Europeans, in terms of all common cysts, they don't have a nice flow chart, but they talk about when it's time to do EUS-FNA. So in cases where the CT and MRI are unclear, you can't see a communication with the cyst to say it's IPMN, you may want to consider EUS-FNA. And if you do EUS-FNA, they talk about doing CEA and to differentiate between mucinous and non-mucinous. And they said that basically, you only perform it if you expect to change clinical management. If the patient is not fit for surgery, do not do EUS-FNA. And also, if you are very clear that there's something that can be seen straight on the EUS, on the CT or MRI that shows there's a IPMN, you may not need to FNA. Or if there's a clear indication for surgery, you also do not need to FNA. Okay, let's talk about IPMN guidelines, and these are the ones that I tend to follow. This is the European ones. It's quite similar to the international consensus. And basically, first thing is always, if patient is unfit for surgery, you can discharge the patient. There's no need to follow up because even if it transforms, you will not offer the patient a surgery. And then they talk about absolute indication for surgery is basically when you have one or more of the criteria, which is positive cytology, jaundice, or a solid mass, or enhancing mural nodule. So once you see any of this, you go straight to surgery. You do not even need a EUS-FNA. And one of the things that where we come in is usually when there's what we call relative indications, and you may want to consider EUS on the surveillance program to look for any of the worrisome features that transform into malignancy. This is the 2017 international consensus that most people will follow. And it's pretty much the same as the European guidelines, talking about differentiate them into high-risk stigmata, in which straight away you go straight to operation. When you have an enhancing mural nodule, pancreatic duct dilated more than 10 millimeter, or you have jaundice. And worrisome means clinical pancreatitis or imaging features. And these are the ones whereby if there's none, you put them on a regular surveillance program. So there was a question that came up is, do we survey all people who are less than 1 centimeter? I think it all depends on your setting where you're practicing in. If you are practicing in community setting with little support, and you may want to put them on the American guidelines, the AGA guidelines, which says after 5 years of stability, you may want to stop. But for people who are practicing in the pancreas surveillance program, most pancreatologists all will actually survey them every 2 years, because if you are truly IPMN, they will eventually grow. Okay. So just briefly going through some of the investigations that have been coming out over the years. When we look at cyst fluid, we know that the cells can have DNA, RNA, proteins, and metabolites, all right? And this is what people have been studying in various forms in the cyst fluid to help make a diagnosis. And if you look at it, this is the latest gut paper that shows a multi-center study involving many centers in the US. And they found that basically using a next generation sequencing, if you are KRAS or GNAS positive, you are most likely 100% going to be IPMN and MCN, all right, which gives you about 30%. And if you have TP53 or PI3 P10 mutation, you have a 9% chance of it being an advanced neoplasia. So I think this is something that's very interesting. With next generation sequencing coming on board, people will start to use this more to diagnose this. So if you look at what they found, this is exactly what I mentioned. You can have high sensitivity and specificity using this technology. MicroRNAs are still being studied, and at this point of time, I would say it's not ready for prime time. So this is under the RNA level. Proteins at the same thing is also mainly looking at milk proteins. These are all very big proteins, so to study the cyst fluid for it is not easy. This is from the Japanese showing that the different types of mucin produced at different stages. So if you're IPMN, you actually will transform from a milk 1 towards a milk 2, and finally you can milk 5 AC when there's actually invasive cancer. So we know that as the cells change in the cyst, the type of mucin they produce also changes. So this is something interesting, but it's still also not ready for prime time. Metabolomics, this is by the Stanford group, Walter Park. He's found that basically glucose is raised when the patient has got a serous cyst, because serous cysts have cuboidal cells which are glycogen producing, and therefore you get glucose. And I think this is validated by a multi-center group from Indiana, including one of the Indiana surgeons, Max Schmidt. And I think it's very interesting because they found that the cyst fluid glucose was much lower in mucinous and much higher in the non-mucinous, i.e. the serous. So when they used a 50 milligrams per deciliter cutoff, they found it was 92% specific and 90% accurate. So I think this is something that eventually we can, it is further validated in other centers around the world. It may be something that could be quite easy and simple to do, to test cyst fluid for glucose. If it's very, very high, you're most likely dealing with a serous cyst. And you can see over here, this is what they've kind of shown, that once you have high glucose levels, you're more likely to think of serous. And if you are a mucinous, which doesn't have the cuboidal cells, it's likely to be low glucose. Looking over here, the serous all have high glucose, nothing below 50, whereas the MCNs and IPM all mostly lower. All right, so this is something that we can keep at the back of our minds. Okay, so now moving to direct imaging or optical biopsy of the cyst via confocal imaging by Kongkam in 2011. And using a 19-gauge needle, we actually put in a laser probe to actually look into the cyst wall. And if you can see, this is what an IPMN would look like with finger-like projections. And this is serous cyst, is a fine reticular network of vessels. And you can see very beautiful images from the CONTACT study and the INSPECT study showing the different types of epithelial lining. And subsequently, even more papers showing how serous cyst will look like. And this is what a mucinous cystic neoplasm or MCN, an ovarian type stroma, would have. This is a pseudocyst with a starry sky appearance of inflammatory cells. And over here is a neuroendocrine tumor with what you call a dense stroma with interspersed duct cells stuck in between. And on a review paper in 2005 by Ken Chang, and they found that basically it's a pretty safe procedure, probably about 11% risk of complications, mostly pancreatitis and some intracystic bleeding, but nothing too serious. And I think as the price of this may come down, more and more people may start to adopt this to help make optical diagnosis. This just came out this year from 2020 from Som Krishna, which me and Pradermchai worked with for multi-center work for confocal. And they look at 144 PCLs using histology as a reference standard. So that means they compared to surgical specimens. And they found that you could identify mucinous cysts pretty accurately with NCLE, 97% accuracy compared to the standard, which is CA and cytology. So you have an increase of 20% increase in accuracy using NCLE. And there was actually significant difference. And over there, the pancreatitis rate was much lower at 3.5%. Of course, they had the benefit of learning from the early adopters, or the people who started first. And now the techniques are much more refined such that we minimize pancreatitis using different techniques. So quickly going on to improving the actual histology and not optical biopsy. We have now the new needles that come out through the needle biopsy, the Moray forceps. And we have papers coming out from the US, from Dragunov, and showing that a multi-center study, TTNB gives you a good success in terms of getting diagnostic yield. It also shows that you can diagnose, based on TTNB alone, 34% of mucinous cysts. Complications were actually acceptable, with some limited bleeding at 2%. And you can see over here, just TTNB alone gave you a very good diagnosis for mucinous cysts. And another study also coming out 2018 from CGH Young's group, they showed that basically TTNB was pretty successful in 97% of the cases. And you can get tissue, actual real tissue, about 83% of the time. And you can diagnose a cyst that's mucinous in 53% of them. And if you have an equivocal cyst, like a previous cyst that was evaluated in another center, when they use TTNB to repeat the biopsy, they could get a diagnosis in 50% of them. And for surgical concordance, all of those 14 who went to surgery, TTNB gave 100% concordance compared to FNA. And TTNB can pick up more advanced neoplasia. And similarly, they had a less than 10% complication rate in terms of pancreatitis or bleeding. So if you actually look at this busy slide, you can see that for FNA, a lot of times you get non-diagnostic, diagnostic in terms of cytology. But once you have histology, which is actual chunk of tissue, you can actually say the dysplasia, whether it's low grade, and when they confirm it on the surgery, there's actually high concordance. Only thing that was difficult was fibrous stroma, chronic pancreatitis. They could not get enough tissue or to call it chronic pancreatitis, and that's understandable because stroma is hard to biopsy and you cannot really tear off the fibrous tissue. So I think this is probably the weak link is only for chronic pancreatitis and the cysts that come with it. So just to give you an illustration of, to keep things in perspective, this is a 74-year-old man who presents with a cyst in 2007 with multiple medical problems. As you can see, this is a cyst over here on the CT scan. It's very clean cyst, 1.8 centimeter. So based on that, the patient was put on a surveillance program. As I mentioned before, this is incidental, and therefore there are no worrisome features, no symptoms. We will put them on surveillance. And it does not fulfill criteria for FNA because there's also no worrisome feature. We follow on with MRCP, same thing. There was actually no worrisome features, and there's probably a ductal communication. And CA from the blood test was normal, and we followed him. 2 years later, the cyst was still about the same size, and same thing, it was no dilatation. And in 2012, probably about 5 years down the road, the cyst has started to grow in size, and this started to ring a bit of alarm bells. But similarly, we wouldn't really touch this patient just based on cyst size growth at this point of time because growth is not more than 5 mm per year or every 2 years. So we actually will watch him. And in 2014, it still continues to grow, but now there's a new interval soft tissue development. So for you, I hope you can see where the arrow is. There's this nodule here and this nodule here. And this is something that worries us straight away. One, there's a nodule inside, we know there's already chance for dysplasia, whether it's low or high grade, we wouldn't know. And the patient underwent an MRI, and the same thing is we could see the nodule over here, which is a void in the fluid field. And you can see it's bright, the same as the aorta. Therefore, there is some enhancement. And straight away, if you see enhancement, we actually would tell the patient that he should be considered for upfront surgery. But the patient was not keen for surgery because he had so many comorbidities and it was a Whipple. And therefore, he was referred for confirmation to get a diagnosis of malignancy. And I'll play the EUS video. So you can see this is a cyst with a nodule inside, all right? And you can see that there's the pancreatic duct over here, all right? And you can see, yeah, this is the PD. It connects towards the cyst, okay? And this is the nodule. So this is what I would normally do. I would actually show the ductal communication, okay? And usually what I'll do is I'll measure the cyst and also dimensions, and I also measure the cyst wall thickness. Cyst wall thickness is something that people routinely measure because they think that it can imply there's some early changes occurring along the epithelial then. And the nodule again is measured. And what we're going to do now is the needle. This is a 19 gauge needle, and you can see it's actually a little bit difficult. And during that time, we are doing confocal. So we actually put this patient under confocal imaging. And you can see over here, this is what confocal imaging will look like. You can see straight away, they're actually what you call bands of front-like, finger-like projections. And if you actually were to go to the still images, you can actually see these darkened bands, and these are all the nuclei, and these are all the finger-like projections to suggest that this is likely an IPMN with possible dysplasia. So we actually managed to get an FNA of that nodule, and it actually showed low-grade dysplasia in the papillary projections. And this is what the cytology yield showed, and with the dysplasia over here. So this man eventually underwent surgery, and the surgery confirmed that it was actually IPMN with dysplasia, but it was only 2 years later he went for surgery. Just to show you a different patient, this is actually using the moray. You can see that the moray is going through. You can see the artifacts caused by the metal. And what happens is that you have to open up the moray at the tip. And you can see that this is the tip starting to open. It's a forceps. And you have to apply a firm pressure upon the opposing wall. Okay, sometimes you jiggle a bit, okay, to open up the forceps. And you apply on the opposite wall. And then you close it. And then you start to pull back. Only when you see this tenting, then you know you have got the tissue. You give a sharp tug, and that's when you can get that nice chunk of tissue for cytology or histology. All right, so I'll now cover briefly EUS for treatment, and this is something which one of the questions put out: when do we consider EUS for treatment ablation? And now we know that what started out was alcohol, before alcohol plus paclitaxel, and now paclitaxel plus gemcitabine, and more recently RFA. So I think this is a nice review paper from DeWitt and from Indiana, and basically he shows a nice diagram. You puncture the cyst, you aspirate till it's almost dry, and you can lavage if you're using alcohol. All right, but however, recent CHARM study shows that alcohol does not make a difference. They actually randomized into alcohol plus chemo drugs versus saline plus chemo drugs, and they found that alcohol-free cocktail was actually just as good as without alcohol. And therefore, we now know that if you want to ablate, it may be safer to not use alcohol. All right, so after you suck out all the fluid, you re-inject with the ablative treatment, and you let it dwell there for the ablative treatment to destroy the epithelial cells. And this is a summary from that paper that shows all the different papers that have been done so far. As you can see, it started in 2005. So after 15 years, you can see the names are all pretty same, the same people doing the same thing. Because I think in the world right now, there are very few people who want to try this, especially if the chance of having a 100% cure is still not on the cards yet. But what's interesting is to know that it has changed from using pure alcohol to alcohol plus paclitaxel, and to more recently to even not having alcohol. And they found that if you do not use alcohol, the pancreatitis rate is 0%. So I think that all these complications of pancreatitis mostly came from alcohol. So I think the future, if people want to move down the path of ablation using fluid, you probably would need to use an alcohol-free agent such that you prevent the complications. This is a paper also that talks about how alcohol does not ablate the cystic lesions. They found that for one patient, eventually developed pancreatic adenocarcinoma due to a treated IPMN 41 months after the lavage. So I think this is from the Mayo group, and I think this should tell us that, you know, if you want to go down the path of ablation, you may not want to just use pure alcohol alone. You may want to either switch to a anti-neoplastic agent, or if you want to continue alcohol, just be sure that you have anti-neoplastic agent. All right. This is from the Asan group, and they use both alcohol and paclitaxel. And they have one of the largest studies series, about 164 patients. However, interesting to note is that they actually include things like cirrhosis and cirrhosis and indeterminate cysts. I think that's the criticism that most experts say, that this study may be slightly biased, because if you treat a cirrhosis, whether you treat it or not, you will unlikely to grow. Same for a cirrhosis. But anyway, the main important thing to note is that when they followed up these patients for a long time, these are in terms of years, they found that a lot of them had complete resolution, and only a few of them did not have resolution. It's about 70%, and adverse events were acceptable around 10%, and this is something which you have to take note of. You can get main pancreatic stricture is what most of the people fear most. Things like portal vein thrombosis and bleeding and pancreatitis are also other common things. So I think they found that they would say that 98% will remain stable at 6 years after use ablation, and this is something that we will have need more data to show if you were to do a study versus surgery. Okay, so let's talk about EUS RFA, and basically it's this using the Habib 1.2 millimeter catheter, and it's also a multi-center pilot study, just studying 8 patients only, by Michel Kale and Bill Brugge and all Sandeep and other people and Habib. And they found that basically it was safe with tolerable cases, and the resolution rates were probably about 100% to 50%. But these are only 8 patients, so we can't say too much. And this is the one that's most recent that came out from the French group. But this using a different RFA, is using the StarMed, and they looked at 30 patients as a pilot study. They studied both cystic NET as well as IPMN or MCN with high-risk features, 14 NETs and 17 PCN. Same thing, complication rate about 10%. And they had a resolution of 86% for the NET and 70.6 response for PCN. So you could say it's still not a cure for all of them, but it's pretty good response. And this is what they've shown at 12 months. There's actually either necrosis for the NET tumors, and or there's a decrease in the size or destruction of the nodule for the PCNs. Okay, so just to summarize this lecture, is covering many points. I think first thing you need to know is that EUS is important. It helps to differentiate, and cross-sectional imaging alone usually is not enough. So therefore, EUS, if you're going to do it, use your imaging to look carefully. If you can, use FNA to analyze the fluid, and you may want to consider following the guidelines according to what you're capable or what your center is looking at, whether you want to be looking at a pancreas specific follow-up or you want to be more general. There are new what we call diagnostic capabilities with omics. I know not many people around the world are using it, but if you're in a center that has these capabilities, you may want to consider it. And DNA seems to be leading the race at the moment, the GNAS as well as the PTK. And metabolomics, I think, is very exciting. We just need more studies to come out. It may just be taking over DNA if glucose testing is really cheap and available. Intracystic imaging, which is confocal, I think is something very exciting, but likewise cost is an issue. TTNV, definitely, you can get tissue, and I think it's quite readily available to most people, but you have to be comfortable with the 19-gauge needle. And with regards to ablation, I think it's experimental, and we just have to be very careful before you go down the path of using alcohol ablation or RFA ablation. You make sure you have to be part of a study because the complications can be severe. So just to give you my personal take on this, if I have an incidental pancreatitis, what would I do? If based on scan, I don't see a ductal communication, I don't see anything worrisome, the patient has got a large enough cyst size, and I may want to consider EUS FNA, especially something worrisome about the cyst, dilated ducts or anything that makes me worried. And I'll try to get a diagnosis looking at the CA. If it's less than 5, I'll say you're likely to be serous, may even discharge them. Or if NCL or the shows that it's a serous cyst. If you don't really have a good answer, I'll continue surveying them. Or if your answer that's mucinous, then I will actually survey them still, because I will put them under the IPMN or MCN group. Anything is worrisome, same thing, you have to FNA or go straight to surgery if the patient is very worried, such as a cyst in the tail of pancreas. So you have a tail of pancreas cyst, 2.5 centimeter, anxious, worried, 40-year-old woman, sometimes upfront surgery is an indication, because otherwise you may have to survey them lifelong. So if you have someone with a cyst that connects to the duct, sure you think it's IPMN, I will actually follow the IPMN surveillance guidelines rather than the general guidelines, and I'll actually FNA based on worrisome features, negative survey, positive surgery. But the take-home point is that every time you do FNA, it needs to make a difference. If the patient is too old, don't bother, or if the patient is too unwell, multiple comorbids, don't do the FNA, because we shouldn't do doing surgery on these people. Therefore, if don't do surgery, means don't do FNA. And likewise, the patient is very young, you really need to consider offering surgery, because especially if it's in the tail of pancreas, it will solve the problem for the patient, and the patient doesn't need to have 30, 40 years of follow-up of MRIs or CT. So with that, I thank you, and I'll be happy to take any questions.
Thank you, Dr.
very much.
Excellent and very extensive talk. And I'll hand over to Dr. Chris for the second part of the session, for the second lecture.
Okay, thank you, Damien. Terrific talk as always. I know there's going to be quite a few questions, but we'll take them right at the end. So it is my pleasure now to introduce Dr. Pradermchai Kongkam from Chulalongkorn University Medical Center. Dr. Pradermchai also is the president of the Thai Association of GI Endoscopy. He's also the director of endoscopy, the King Chulalongkorn Excellence Center. And they've done a lot of good work, a lot of publications coming out of there, and many of them from Dr. Pradermchai, doing some really innovative stuff. And I'm sure he's going to be talking about some of these things. He's also, not many of you know this, but he's also the president of the Ambulatory Medicine Society of Thailand. So, ambulatory procedures, that's his specialty as well. So without further ado, I'm going to hand you over to Professor Pradermchai to speak about EUS biliary drainage. Over to you, Pradam. Pradam, you need to unmute your speaker. Click on. Okay,
yes.
That's it.
Okay, terrific. All right. Thank you very much, Chris, and nice to meet you, Adeel and Damien. And you have done very good for your lecture. I'm very happy to listen to your wonderful lecture. So my job today is about the EUS-guided biliary drainage. So now, can you see my slide at this time?
Yes, we can.
Okay, you can. Okay, all right. Thank you. So here is my hospital. And as Chris kindly introduced me, I'm working for this Chulalongkorn Hospital for a long time. And also currently the Thai Association for GI Endoscopy, we are moving forward to develop and try to teach and distribute all kinds of the procedure to all our members and also to all our friends in the Asian countries, and I think that everyone know very well. So my job today is talking about the EUS-guided biliary drainage. My topics, I will cover why do we need EUS-guided biliary drainage, indications and contra-indications of EUS biliary drainage, and also types and selection of EUS biliary drainage methods, and also the endoscopic techniques and case success rates, adverse event rates. So we start with the first topic. Why do we need EUS biliary drainage? That's because ERCP fail in about 10 to 20% of malignant bile duct obstruction. That's the origin of the story. That's why we need EUS-guided biliary drainage. Because in the past, we sent patients who fail ERCP to have PTBD, which you know very well that PTBD is long-term care is cumbersome. Like in this picture, you can see that in this picture, patients have bile leak from PTBD and bile irritating his skin. So cause some itching rash and also some local complication. And surgical bypass seems to be too invasive for palliative biliary drainage. So that's why we need EUS-guided biliary drainage. So now you know the reason why we need EUS biliary drainage. So then you can tell your directors of the hospital to start EUS biliary drainage service now. So how about the current indication and contra-indications of EUS biliary drainage? The current indications that widely accepted at this time is in failed ERCP case in experienced hands, because we always try to start with the ERCP first in most centers of the world, and in patients who have surgical outer anatomy. So that patient ERCP is not possible. We don't want to send the patient for PTBD, so EUS biliary drainage is option. Inaccessible papilla from duodenal obstruction also another indication, or if patients want to convert from PTBD to EUS biliary drainage, that's another indication. And recently, a few papers start to compare between primary biliary drainage versus ERCP versus PTBD, and the results seem to be very interesting. How about contraindications of EUS biliary drainage? Ascites, particularly large volume ascites, uncorrectable coagulopathy, or patients have too advanced disease, high ECOG score, patients with pregnancy, or patients have intervening tumor between puncture area and the bile duct, and also some problematic anatomy. For example, people who do not have stomach, like a past total gastrectomy. So then EUS-guided biliary drainage is not possible for that case. So about types and selection of EUS biliary drainage methods. So the procedure of EUS-guided biliary drainage can be divided into trans-papillary route and also transmural route. Trans-papillary route include EUS-guided antegrade stenting. The other procedure is EUS-guided rendezvous. So for EUS-guided antegrade stenting, endosonographer pass the needle through the left intrahepatic bile duct, pass the guide wire all the way across the stricture, and press the stent from up and down to the distal bile duct. This procedure, one might call EACP, endoscopic antegrade cholangiopancreatography, but commonly we use EUS-guided antegrade stenting. The other procedure is EUS-guided rendezvous. EUS-guided rendezvous can be done by two points of puncture. The first one, again, from the left intrahepatic duct and pass the guide wire all the way through the duodenum, and we switch to the ERCP scope to grab the guide wire. The other option is puncture from duodenum and then pass the guide wire back to duodenum again and change the EUS scope to the ERCP scope. So that procedure is a trans-papillary route. And then the other methods, which is much more common at this time, is a transmural route. For transmural route, the simplest procedure in my idea is EUS-guided choledochoduodenostomy. You press the echo endoscope into the duodenum and then puncture the needle into the distal bile duct and dilate the tract and press the stent. That's choledochoduodenostomy or CTS. Hepaticogastrostomy or HGS, connecting between left intrahepatic bile duct to the stomach. And another procedure which is considered a little bit more complex is hepaticoduodenostomy, connecting from right intrahepatic bile duct to the duodenum. It's a little bit complex, but it's possible. So these cartoons show HGS, show CDS, and also show hepaticoduodenostomy in case that we do need that. For example, in patients with malignant hilar biliary obstruction, which completely separate left intrahepatic bile duct and right intrahepatic bile duct. So then, how I select the EUS biliary drainage method for the patient? We start with biliary obstruction, and then we classify EUS biliary obstruction into unresectable malignant biliary obstruction, malignant but resectable, benign biliary obstruction. At this time, most EUS biliary drainage, also ERCP, done for unresectable malignant biliary obstruction, which unfortunately, majority of patients with bile duct cancer, majority of them come to us in unresectable stage. There are a little bit of information using EUS biliary drainage in benign biliary obstruction, but for malignant but still potentially resectable biliary obstruction at this time, in my opinion, I think that we try to avoid EUS-guided biliary unless there is more information in the future that it helps the patient. But at this time, we should avoid. And if we want to do this, we must bring the patient into some randomized controlled trials only. Today, I will focus on unresectable malignant biliary obstruction because the information of benign biliary obstruction and EUS biliary drainage is still not much. So then, once we see the unresectable malignant biliary obstruction, I think that it's essential to divide the patient into a group of distal biliary obstruction and malignant hilar biliary obstruction. Believe it or not, but majority of papers of EUS biliary drainage in the world at this time, I can say more than 90%, they use EUS biliary drainage for distal bile duct obstruction. Only few papers or less than 10% that describe or have applied EUS-BD into patients with malignant hilar biliary obstruction. I will tell you why. So then in malignant distal biliary obstruction, so if you compare how we have antegrade stenting and rendezvous in patients with distal bile duct obstruction, actually my preference, I prefer antegrade stenting because it is single-step procedure, and even the level of the bile duct obstruction is relatively far from the ampulla, is still possible. But for EUS-guided rendezvous procedure, even though it's been published more in the literature, but it's two-step procedure, you need to exchange echo endoscope to ERCP scope. So I'm doubt that we need more information to use this one. Anyway, in the literature, it's been shown that rendezvous has a high technical success rate and clinical success rate, and the complication rate is pretty low. However, you need a good assistant because it's technical demanding to manipulating the guide wire to the desired direction, particularly if you puncture from the duodenum. And if you want to pass the wire through to this one, it's not possible in supra-empyreal duodenal obstruction, because if you want to puncture from the duodenum. So then this is an example of the EUS-guided antegrade stenting. For the technique of EUS-guided biliary drainage, firstly, we place the echo endoscope in and identify dilated intrahepatic bile duct. And typically, we use 19-gauge needle pass in and inject the guide wire. And then for antegrade stenting, we try to pass the guide wire all the way through the stricture in the lower part of the distal bile duct. And the next step, then we will dilate the tract enough to pass the stent through, either antegrade stenting or transmural biliary drainage. So typically, we should start with the cystotome, and I would recommend cystotome 6 French to dilate the tract. And then this can be followed by serial dilator like Schoendas dilator, or you can use 4 mm hurricane balloon to dilate the tract. This is the important part, because we need to use coagulation and also mechanical dilation at the gastric wall and the liver capsule. And in this case, we successfully pass the guide wire to the duodenum, and finally we pass the stent. And all the procedure of antegrade stenting will be done under fluoroscopy view only, because we don't have endoscopic view, and also endoscopic ultrasound view will help you only at the beginning when you puncture the needle and pass the guide wire, and after that you have to use the fluoroscopy view. So, and for how about transmural routes? Transmural routes, I like to divide into the extrahepatic approach and intrahepatic approach. For extrahepatic approach, it's called duodenostomy. Actually, if you want to start EUS biliary drainage in your service, I would recommend you to start with the duodenostomy because it's less technical demanding. However, it's not suitable in high distal biliary obstruction. And at this time, look like that the most appropriate stent is a lens, particularly with the hot axios or because the plastic stent, if you place most of the time, there might be some leakage. And the self-expandable metal stent is possible, but you have to be careful about the migration. And it's a bit more complicated and technical demanding to place the stent to the appropriate place. How about hepaticogastroscopy and hepaticoduodenostomy? Is intrahepatic approach more technical demanding comparing with the CDS? However, it's suitable even in high level of distal biliary obstruction. And at this time, the appropriate stents for HGS seem to be the hybrid stent, uncover and cover parts. And also recently, Professor Takao designed a new plastic stent dedicated for HGS is also an interesting choice. For hepaticoduodenostomy stent, the most appropriate stent at this time has not been designed yet. But in my experience, I use a fully covered stent about 6 or 8 centimeters in length. So the next algorithm in my practice, in patients with unresectable distal bile duct obstruction and not possible for ERCP, if the location of the obstruction is high or the patient even has business 1 or 2, the possible EUS-BD is HGS, antegrade stenting, and rendezvous. In patients with low distal biliary obstruction, if patients have supra-empyreal duodenal obstruction, possible procedure include antegrade stenting and hepaticogastroscopy. However, if patients do not have supra-empyreal duodenal obstruction, so all EUS biliary drainage procedure is possible to help the patient. They include CDS, rendezvous antegrade stenting, and hepaticogastrostomy. So in patients with hilar biliary obstruction, it's a little bit more complex comparing with the distal bile duct obstruction. Why? Because in hilar biliary obstruction, if the obstruction is bismuth 1 or 2, probably there is no difference comparing with the distal bile duct obstruction. But in bismuth 3 or 4, we would love to have complete and adequate biliary drainage to drain all possible segments from the liver. So then the ESG guidelines still recommend using the PTBD because ERCP with bilateral stent is technical challenge, and particularly de novo cholangiocarcinoma, which is very common in Asian countries, including Thailand, Pakistan, and also many Asian countries. It's very difficult to pass the second stent in, so technical challenge. So in some percentage of the patient will fail to press the second stent, and then we have to give the patient PTBD. EUS-BD drainage in hilar biliary obstruction, there's a limited information. And in our center, we have an idea of combine ERCP and EUS, and we name this procedure as a series procedure or combination of ERCP and EUS. It seems to be interesting because it's combined the conventional ERCP to drain one segment, and then we use EUS-BD drainage in other segments that also need drainage as well. So the most recent review of EUS-BD drainage in hilar biliary obstruction came from Nagai and his group, all include Professor Isayama and also Professor Koike. Total number of the patients from multiple small case series is only 88 cases, even though the technical success rate is reported high at 98%, but the clinical success rate is only 77%. Interestingly, adverse event rate of EUS-BD drainage in hilar biliary obstruction is only 8%. And I think that we can explain that's because at the beginning, most people we start with the distal bile duct obstruction, and that's a learning curve. So that's why complication rate is too high. And then when we have more experience, we start and we move to the hilar biliary obstruction. And certainly only very experienced doctor that will try EUS-BD drainage in hilar biliary obstruction. So that's why they can control the adverse event rate, and the complication rate is relatively lower than general complication rate of EUS-BD, which at this time reported about 10 to 20%. So if we look at the hilar obstruction, we try our best to place multiple stent in, and then but sometimes we cannot. So then we might have to offer the patient for another additional PTBD to help the patient to have adequate and complete biliary drainage. So how about if the patient have one ERCP and then we press another HGS stent to drain more? Or if the ERCP stent go to the left side, then we do the hepaticoduodenostomy. Or if ERCP cannot get beyond the obstruction, or they can, but multiple segments still remain and that need to be drained, we can do both HGS and HDS to completely drainage biliary obstruction. So then this is one of my case which may be a little bit complex. The patient has malignant hilar biliary obstruction, and then certainly we like to try the ERCP first. This is a mass about 15 millimeter in the hilar area. In this case too, we try to confirm the diagnosis. We use a spyglass and we did the biopsy, and the pathological result of the biopsy confirmed cholangiocarcinoma. We pressed one ERCP stent. Unfortunately, it couldn't get across the obstruction. So we pressed hepaticogastrostomy stent to drain the left intrahepatic bile duct. So this is a hepaticogastrostomy stent, but the patient still has fever. And then we look at the cholangiogram, we found that, and we did a CT scan, we found that this is a HGS stent, and this is an ERCP stent. The patient still has dilated right intrahepatic bile duct. So then we press our scope into the duodenum, and we pass the needle into the dilated right intrahepatic bile duct. We inject and we dilate the tract, and we press the fully covered stent connecting from dilated right intrahepatic bile duct through the duodenum. So then the techniques that we use to deploy the stent, at this time, everyone know very well that we use deploy intra the scope. This can control and prevent migration of the stent very effectively. And this is stent came from right intrahepatic bile duct to the duodenum. This HGS stent, ERCP stent, and this is a hepaticoduodenal nominal stent. So after this procedure, the patient can go back home. So another case is a 51 man and also have hilar cholangiocarcinoma. So then in this case, we did the CRS procedure by, this is hilar obstruction. We placed one ERCP stent and another hepaticogastrostomy stent, which is actually CRS procedure. But unfortunately, even though bilirubin came down, but the patient still has fever. So then we did the CT scan. We found that the bile duct in the segment 2 has been completely drained by the hepaticogastrostomy stent, but the segment 3 is still be dilated. So then we decided to do another HGS stent to the segment 3. I placed my scope here, and then I identify dilated bile duct in segment 3, and I passed the needle, 19 gauge needle. We inject the contrast to demonstrate. And when we inject harder, the bile duct has been dilated, and some of the dye get through the segment 2 and back to the stomach, as you see. And now we dilate the tract, and then we place the hybrid stent. And then this is a shadow of the stomach. The hybrid stent has uncovered part, which we want it to be totally inside the liver. And then outside the liver, across into the stomach, we like to have it to have the membrane in that part, or the cover part inside the to cover and prevent the leakage. So this is a HGS stent from the segment 3. And then while we were withdrawing this is a segment 3, and that's a segment 2. Sorry. Okay, we see 2 stents in the same picture. So we had our multi-center prospective comparative study compared the CRS procedure versus PTBD had been presented in many press around the world. And finally, we got our paper published in endoscopy journal just this last couple weeks. And the technical successes of CRS versus PTBD is 84 versus 100%. Clinical successes is about the same, around 80%. Complication rate 26 versus 35%. The interesting point is that recurrent obstruction rate requiring biliary intervention procedure in CRS within 3 months is only 26%, comparing with 88% of PTBD. And at 6 months, it's only 22% because some patients die. But in PTBD, it's 100% within 6 months. So then this is interesting information showing that if we can accomplish the CRS procedure, then we can reduce the number of the hospital admission or number of the future procedure from the PTBD. So then this algorithm show that in unresectable hilar obstruction, good ECOG score, and the patient still have enough liver volume, then if the patient has functioning both lobe, we can do ERCP to the right side or HDS plus ERCP in the left side or HGS. And if the patient has, this is functioning only one lobe, but if the patient has functioning both lobe, then we can do ERCP on the right side and HGS, or ERCP on the left side and hepaticoduodenostomy. So this is the idea of the algorithm. How about the adverse event rate? Certainly, the procedure has adverse event rate, and I will show you 2 cases of the my complication at the beginning. And both procedure done outside my hospital, and we had this complication in a provincial hospital. the patient has a bile duct obstruction. So then we try to do the EUS-guided hepaticogastroscopy, but our stent went away, and the end in the liver is okay, but the other end, they went into the stomach, and the puncture hole becomes bigger. So then the patient has a compartment syndrome. So then unstable vital sign. So then what we do, we puncture the cylinder with the needle, fill with the water, and we let the gas come out. So then if you start EUS-BD drainage procedure in your institution and you have such complication, a lot of air in the abdomen and the compartment syndrome happens, don't be panicked. Just press the cylinder in with the needle and fill with the water and let the gas come out. And this case, after gas came out, then vital sign became more stable, and then we can continue the procedure until we finish. So we can fix this one. So the next case is the leakage at the liver and the stomach junction. This happened to me once in a while because many of my cases is hilar block. So when it hilar block, so then the length of the intrahepatic bile duct is very short. So then sometimes uncovered part came to the junction between liver and the stomach. So the leakage happened. So how can we fix this complication? This is a patient with hilar biliary obstruction, underwent serous procedure. So then during the hepaticogastroscopy, we pressed the stent, but at that time, we didn't use, the length of the intrahepatic segment is very short. So then after we deploy the hepaticogastroscopy stent, uncovered part is still located between in the junction between liver and the stomach. So then the patient, after the procedure, she has pain and also peritonitis from the bile leakage. So what we do, we use the ERCP scope, went back again, and then we cannulate the catheter and the guide wire into the HGS stent, and we press another fully covered stent. This is a HGS stent, and now we cannulate with the ERCP scope and press a fully covered stent to block the leakage of the uncovered part. And after this fully covered stent was pressed inside the HGS stent, no more leakage, and we can discharge the patient back home. And we confirm by the cholangiogram through the HGS stent and through the fully covered stent as well. So that's also another complication in patients with hilar biliary obstruction. So then overall, this is a most recent systemic review in 2020, published in EUS journal. And you look at that, the clinical and technical successes seems to be higher with the later publication. And the adverse event range between from 5 to 20%. So my conclusion about EUS-BD drainage at this time, I think that EUS-BD drainage at this time is another interesting alternative for BD drainage, and it becomes the real-life practice in some hospital, even though not many at this time. But in the future, I think that it's a future of BD drainage, and it will become friends, close friend, best friend with the ERCP, but it's not an enemy. I don't like the word enemy. But if you want to do that, you need to be trained with good, kind, and experienced mentor. It's mandatory because EUS-BD drainage always have a complication if you don't get the training under the experienced mentor. Adverse event rates, in my opinion, seem to be decreasing with proper techniques and under good training. However, dedicated device, including stent, dilator, needle, coagulator, and also echo endoscope are needed. And for Pentax, the Pentax company kindly developed the EUS-J10, which is very appropriate for EUS-guided BD drainage because it's slimmer, and the length of the needle to come out from the EUS scope is wider. So then it lets the EUS guided bleed drainage more flexible and easier. Then we can go for more area of the bile duct, which sometimes even 1 millimeter angle or 2 millimeter angle, it change a lot, change from failure to the successful procedure. So, and I like to end my lecture with this picture of my close friend and my mentor, Professor Chris. And thank you very much. I end my lecture at this time. Thank you.
Thank you very much, Pradam. Actually, you are my mentor, you know.
Oh, no.
The other way around. That's a terrific talk, Pradam. And I just want to echo what you said about, when it comes to if you're starting EUS biliary drainage, you need to learn. Don't do it yourself. Your first few cases, you must learn from somebody who's experienced, because there's a lot of tricks, that we can't deal with. We can't talk about, you have to learn it really with your teacher right beside you. I think the second point also is that, you need to do this with CO2 insufflation. That will really minimize your risk of severe complications. And if you do develop pneumomediastinum or capnoperitoneum, you need to recognize it quickly and drain it very fast. Otherwise, you may risk losing the patient. So those are just the additional points I wanted to add. But we'll go to questions now, Pradam. I think Adeel, will moderate the questions for
Sure.
Damien.
Sure. So we have for Dr. Damien, we have a question from Dr. Nadeem Tehami. What are the risks of bleeding, infection, and more importantly, pancreatitis when you're using a microscopic biopsy, Moray forceps, or NCLE?
Yeah, so I think it's all around 10%. If you look at my slides earlier on, for NCLE, it's about 10% risk of pancreatitis and bleeding. But the most recent paper by SOM is come down to about 3.5%. And if you want to do NCLE, the early papers were all doing what you call the exchange, which means they puncture with the stylet in. And when they did the exchange of putting out stylet and putting down the laser probe, that's when you cause the pancreatitis. The earlier studies also, people were putting the probe too close to the cyst wall. So there's a lot of friction and irritation. So that's where you get the bleeding. So I think now, if the techniques being described better, I think if you want to pick it up, you should get a mentor like what Pradam has said also, who will take you through. I think the risk will probably come down to 45% and less for the confocal. For the biopsy forceps, I think it's inadvertent that you get some bleeding, because I've done it, and after you biopsy, it's a big chunk of tissue that comes. There can be bleeding.
Dr. Damien, can you stop sharing, please, by clicking on stop presenting?
I think it's Dr. Pradam. If you can stop sharing, Pradam.
Okay,
Yeah.
great.
Yeah. So So I think for
Okay.
Moray, it's one of those things when you biopsy, there will be some bleeding, but I think it's not significant. Pancreatitis is just part of it. I mean, compared to the original brush biopsy that was done in the past, I think there's so far, touch wood, been no deaths and nothing too serious. So I think it's all right, the Moray.
Damien, you're talking about the Cook Echo brush, was it?
That's right.
Right.
Yeah.
So that's off the market now because there were bleeding, and was there severe pancreatitis as well?
There's one case of death. Yeah.
Okay.
So I think this Moray is much safer because we're only doing targeted areas. You're focusing on usually the nodule, or if you're going to biopsy, it's only just one area. And the recommendation is you try to biopsy the cyst wall that's next to the parenchyma, not a free floating, the one that's on the not covered by tissue.
So Damien, there is another forceps from MTW. Is there any difference between that and the Moray?
Actually, personally, I'm not used to MTW one. I mean, I've been trying to get it, but it's apparently not so easy to get. So my only experience is the Moray, but I think it should work the same.
But what's the rough cost of the Moray?
I think it's quite expensive. In Singapore, it's about
It's pretty steep.
$800, about $600 US.
About double the price of the needle, huh?
That's right.
Okay. There is a question from Vikrant from Ireland. And I think you answered that, but which guidelines do you use for PCN follows? I think you.
Yeah, so as mentioned earlier, there's the general guidelines, there's the IPMN. So I think if you are practicing in a community, you want to not survey them so intensively, the AGA may be the better one. But if you want to be a little bit more thorough, you can probably use the European or the latest ACG guidelines. And if you have IPMN, I think you should follow IPMN guidelines. Okay.
Yeah,
Okay.
Dr. Khor, for questions for Dr. Preman.
Okay. Well, there's a question from Dr. Ravi Ramasamy from Chennai. For Pradam, after biliary gastric drainage, was the biliary gastritis manageable? Pradam, are you there?
You meant biliary gastritis.
Bile gastritis, not the peritonitis.
Oh, I never realized that I have case of biliary gastritis. Yes, actually, they might have, but I think they are happy with the bilirubin that came down, jaundice went away, so they might have a little bit of uncomfortable, but probably they never complained to me. Yes.
I don't think it's been an issue, right, Pradam, in any of the studies or any of the case series. So it's probably not an issue at all. I think what we are most concerned about would be the biliary peritonitis.
Yes.
If there is leakage because the uncovered part is too far out. And the other one would be if the length of the stent in the stomach is too short and with movement it gets pulled through, then you really have a problem. And it can be very serious. But so Pradam, actually on this point, let's say if you put the stent, it ends up being too short in the stomach. Do you do anything to try to secure the stent inside the stomach? Let's say if it's only 2 centimeters inside. How long do you usually want it to be, ideally? And if it's too short in the stomach, do you do anything to try and hold it in?
Actually, to my practice, I leave the stent in the stomach very long, and I try to use the HGS stent as long as I can, either 100 millimeter or 120 millimeter. And with that kind of the long stent and also very long intra-gastric part, so then we never or rarely experience complication of HGS stent occlusion from food because the direction of the stent will go down. So instead of that, there are some experts that leave the intragastric stent a little bit short, but no problem about the leakage, but the problem of the food occlusion and block the stent and cause intermittent cholangitis from the HGS stent were reported from those kind of series. So at this time, look like that everyone seemed to agree that we should leave intragastric stent longer than, at the very least, longer than 5 centimeter, I think, yes. And the other problem that happens by chance, that's because most of my case, the level of obstruction is relatively high. It's bismuth 2 or sometimes 3 or 4. So then we do not have space in the liver that we can place stent deep.
So do you routinely drain the bismuth 4s, let's say, or the 3Bs, because these are really very hard for you to try to drain 50% of the liver. Huh?
Yeah, we what I do, I drain from. I will start with the segment 3 first, because the location of the puncture will be far away from the distal esophagus. But if we cannot, that's because of the tumor, or we fail, or the segment 3 already became atrophy, then we move to the segment 2. But we have to be very, very careful that the puncture site shouldn't get through the esophagus. Okay, if you have no choice, you can try. But don't forget that you still have PTBD in that case. And in most cases, that the liver been invading the segment 3. So mostly the stage of the liver of the tumor is very advanced. So probably it's useless to do the EUS-BD drainage as well. Yes.
Thank you. Thank you.
Have you ever had a puncture of the esophagus into segment 2? And if you had, what do you do?
If I already did, then I cannot do anything. So the show must go on. So we have the show must go on. We have to do that. Yes.
So you will push the stent in the esophagus down across the G junction to the stomach?
Yes. It will become like a reverse U. And then
reflux and difficult dysphagia?
Actually, if you already put the stent, the gastric end of the stent back to the stomach, no problem about the eating. The patient can eat. I don't know why. Yeah. But at this time, look like that we have another choice. We can use the plastic stent, and we don't need to dilate the tract much. But the other problem is that once you puncture in and you dilate the tract, even at that time, you don't know that you are in the esophagus. You will know only when you start to deploy. So then you have to think and you have to compare between the anatomy of the liver and the fluoroscopy, that the deploying area is already inside the mediastinum or not. If you think that it is, maybe you move to other puncture area or you use plastic stent or whatever.
Pradam, do you ever keep an eye on the scope length? Because in most patients, if you're more than 40 centimeters or you can see the GE junction, then you know you're inside the stomach. Is that helpful?
Yes, that's very helpful. Yeah, but also it depends on the types of the echo endoscope, because in some types of the echo endoscope, you can bring the needle very wide range, like a J10 of the pentax. So then with this one, this can also prevent puncture to the esophagus. But if you can move the needle backward to the scope much, you have to do like this. So then there's a high chance that puncture into the B2, you have to puncture across the esophagus.
Thank you, Pradam. Okay, there's been a sudden flood of questions for you, Pradam.
It's also raining in Thailand. Flood of questions and also flood of water in Thailand.
Okay, this is a question from Dr. Tanya Pon in Bangkok.
Wow.
After EUS-BD, is there any problem with some syndrome, especially if you use the stent with a shorter limb in the GI lumen?
Yeah. I think that Tanya Pon might talk about the choledochoduodenostomy, and then and then in choledochostomy, yes, there are some cases that the opening of the stent, they went back through the gastric outlets. So then some food can go in and might cause some intermittent obstruction, but it's not often. And if possible, to my practice, I will try to puncture as far as I can, close to the obstruction as far as I can, because actually at the beginning that we start EUS-BD drainage, we in some certain period of time we said that if the location of the puncture is high up to the duodenal bulb or close to the duodenal bulb, we shouldn't do the EUS-guided choledochoduodenostomy. But at that time, we have only plastic stent. We have only fully covered. But at this day, we have the lamps, which lamps can bring bile duct and duodenum together. So one thing, after you use lamp and you want to prevent some syndrome, one thing you can press another double pigtail plastic stent in. It helps some. Yeah, if you think that the direction of the lamps come back and face the gastric outlet. But that's a good question.
Yeah, thank you, Pradam. It sounds like lamps are really the way to go for CDS now, especially And now you have the choice. Of course, you have the choice of the smaller diameter. You don't need to do a 15 mm. You can always use an 8 or a 10 mm axios. Thank you. There's a question, or it sounds like a kind of a comment really from Dr. Nadim Tahami from the UK, that you can use Ovesco to secure the stomach or endoscopic sutures. What's your response to that, Praderm?
Use Ovesco
to secure the stent and the stomach or endoscopic sutures.
Oh, actually, no need. No need.
Yeah, I think actually, Praderm, very interesting conversation I had with Dr. Mark Bartet when we were together in that EUS days last year. What Mark Bartet does is that he makes use of hemoclips to secure if you have a very short HGS length in the stomach. And then we started doing that after I had that conversation with him. We use something with jaws, and you basically poke the jaw of the clip through the membrane, and you secure it to the wall of the stomach. It's a very cheap way of doing it. It doesn't distort the stent, which would occur with the Ovesco because it's so big. And of course, Ovesco is very expensive as well. But if you put 2 of those or maybe 3 of those, and if you secure it properly, that stent never moves. And we've had some good success with it in our patients with just 2 centimeters sticking out with with very good long-term, so that's something which can be tried. There's no studies to show this yet, but this could be something that we can write about.
Yeah, that's good techniques. Yeah.
Okay. Thank you. Adeel, any questions for Damien from this list?
Yes, we have a question from Dr. Rafe Azar for Dr. Damien. What was your experience in obtaining adequate diagnostic material in using different gauges of needle use during EUS-FNA?
Yes, so thank you, Rafe. Rafe used to work in SGH as our pathologist, so he's a GI pathologist, so I'm glad he's on this webinar. For me,
great, Rafe. Hi.
Yeah, for me, my standard needle is a 19 gauge needle because mainly for cyst fluid aspiration, I find that 22 gauge, if the fluid is too mucous or viscous, you can't suck out much. Secondly, because I do confocal or microbiopsy forceps, only the 19 gauge will allow that. So my standard go-to needle for cyst is usually 19 gauge, and I would try to use, if I can, confocal or microbiopsy forceps. If I can't, or it's a difficult location, then a 22 will suffice. But the goal of cytology in this case then it will be to target the nodule. Yeah, so a 22 gauge needle should try to target the nodule.
Okay, great. There's another question from Kansas City. Dr. Syed is a friend of mine, and he said he had 2 cases of malignant in SCAs in last 10 years, and which make him nervous in his top surveillance. So what was your experience about it?
Yeah, so I think if you read the guidelines, especially the AJ guidelines, they actually mention that SCA is one of those which there's a very low risk of malignant transformation. And every time I tell my patients before I discharge them, you have a serous cyst. The chance of the serous cyst transforming to malignancy is probably like 1 in 100,000 or 200,000. And I would tell them that, I don't think surveying you is going to be cost effective. And of course, if you want to continue surveillance, we would, but recommendation is not for it based on all the guidelines. So yes, I had 1 case, but it was not on my surveillance program, but we had a patient who also had a serous cyst, like 10 years later, came back with a serous cyst adenocarcinoma. But so far, only 1 out of the number of years I've been seeing this.
Yeah. Okay, Dr. Praderm, if he can take on questions. Yeah.
Sure.
Yeah.
Dr. Khor?
Yes, right. So Dr. Arlen from the Philippines, it sounds like, I guess she's a fellow from from before. Yeah.
Nice to hear from you. Yes.
Okay. How do you manage occlusion of the HGS from tumor invasion or progression? Great talk as always, Prof.
Yes. So actually, it's very infrequent that the tumor came and blocked the HGS stent, because once we place the HGS stent, we don't fight with the tumor. We just drain physiologically from the normal bile duct, normal liver, and normal gastric wall. So it's very infrequent for me to see the tumor came back here. But I have a few cases that patients have hyperplasia and from the uncovered membrane in the intrahepatic intrahepatic part of the stent. So what I do exactly about the same with the ERCP stent. I use the balloon and try to clean that up, but I never need to place another stent because it's not a malignant tumor in growth. So it can be managed by clean the stent, and that should be enough. The only case that I need to place the stent inside is a leakage of the bile duct or of the bile fluid, so that I have to place another fully covered stent in. Yes, and it's very interesting, very interesting to see the patency time of the ERCP stent versus HGS stent. It's very interesting to see the long-term result. At this time, majority of the paper, or almost the paper, they report the short-term clinical outcome of the stent, but they never compare the long-term outcome of the ERCP stent versus the HGS stent in appropriate patients. So I meant in the randomized control trial. Yes, it's very interesting to do that. Yes, and everyone wants to know, I think. Yeah.
Yeah, excellent point, Pradam. Actually, that leads us to our next question from Dr. Om Prakash from Karachi. And his question is, with serious, you mentioned that the recurrence of blockage is low, 2 out of 9. So what is the outcome of the remaining 7, and what is the survival rate in both groups, and which technique is more cost effective?
Yeah, in both groups of patients, the survival rate is not different because the patients who came to see me, they are bismuth 4 and they have advanced stage tumor. They have intrahepatic metastasis as well. So actually, I tell you my idea. I think that the cholangiocarcinoma, if we can pick up the diagnosis at the early time, and we can give the patient adequate drainage, it's probable that the patient might live longer than patients who do not have adequate biliary drainage. Because I think many patients who have cholangiocarcinoma, they die from insufficient biliary drainage. They die from biliary cirrhosis. They die from recurrent infection because of not good enough drainage. If we can develop more good and clean enough biliary drainage, probably patients might live longer and they have more chance to get the chemotherapy instead of they don't have chance because always have recurrent cholangitis off and on. That's my idea, but we need hard work to prove that. And I hope that one of the audience tonight that you are listening to all of us, if you have effort, you have power, you have time, you should do that, yes, in the future.
Yeah, Pradam, just to remind you, the American Journal of Gastro did a randomized control trial on EUS-BD versus ERCP by the Koreans. The main author, so they actually had a higher patency rate for the biliary drainage compared to ERCP. Of course, that was a 3 months survival patency. I think the evidence all is now pointing towards EUS-BD as a longer patency because we don't go through tumor.
I also read that journal. That's a nice one. It's published several months ago. There's very few study comparing that. So but actually, I cannot remember that study has something that needs has some room for improvement. But I have to go back and look at that. Yes, but we need more. We need more. Yeah.
They use a stent delivery system that's not available outside Korea.
That's right. Unfortunately, it's a Cole's dilating system. 7 stretch,
Yes.
So very fast, 6 minutes.
But we always still want to keep the ERCP in, Chris, right? Yeah.
Yeah.
Right, yeah. I think
We don't want to
everybody,
let go
all
of
the
that.
audience, I mean, everyone agree that ERCP is also good because natural roots, right? Yeah.
Yeah. Pradam, one more question for you from Dr. Atif Majid from Karachi. Do you have any preference for a stent depending on the extent of malignancy? So different stents for different length of the or extent of malignancy?
Actually, I also point out in some of my slides that for the CDS, at this time, I prefer lamps, and actually the hot one is make the procedure easy, 5 minutes procedure like a pseudocyst drainage, right? And then, but for the hepaticogastrostomy stent, I think it's still debatable between hybrid stent and the plastic stent. The hybrid stent and the plastic stent, it will be the near future question comparing between the plastic stent specifically designed for HGS versus the hybrid stent, which one is better? Because I mean, everyone know very well that metal stent been designed for patients with end-stage disease. So most of the time, the membrane will be there only for 1 year or something. And then if patients live longer than that, particularly in patients with benign biliary obstruction, so then plastic stent will get will win in terms of the long. But we don't know at this time, but we have to compare. And the hepaticoduodenostomy stent, I think, still fully covered. And I have used plastic stent 1, but in that patient, the patient has benign stricture and separate between left side and right side of the bile duct. So then he doesn't want surgery. So until now, I have followed the patient for about 4 years. At the beginning, I used a fully covered, but we have to take it out after longer than 1 year. We press a plastic stent in, but it wouldn't be there. It came out. But later on, after 2 years plus, it became fistula. And we don't need to place any stent furthermore. So it became hepaticoduodenostomy fistula, and the patient still doing well at this time. And he doesn't need hepatectomy just to kill the complete obstruction between right and left system. Yes. So many more questions that need answer in the future for EUS-BD drainage. We are just at the beginning era of the EUS-BD drainage.
Okay, thank you, Pradam. Question for Damien. Any role to just drain a large SCN with abdominal fullness symptoms, or would that patient go to surgery, or might that patient go to surgery?
Yes, I think it's from Ahmed. Ahmed, hi.
Yeah. Oh, is that Ahmed? Oh, yeah.
Ahmed from Bahrain. Yeah,
hello,
hi.
Ahmed.
Fellows, nice to meet you, Ahmed, again. Yes, I think the guidelines for the serous cyst is mostly from the surgical series. Any serous cyst that's usually more than 5 centimeters or causing symptoms is an indication for surgery. I don't think we should drain it, because if you drain it, it will just recur and the patient will get recurrence of symptoms. So I think once serous cyst cause symptoms, surgery is the main choice.
And a comment from Dr. Nadim from the UK again. The stent fix OTSC system set might be useful for HGS. We haven't seen that yet because things reach us a little bit slower, I think, from Europe. But we will certainly look into it. Thank you. Do we have any more questions? Well, it's great to see Ahmed here and Rafe as well. Fantastic.
Okay.
So no more questions.
All right, great. Okay.
Adeel, back to you, Adeel.
Yeah, okay, very nice session. And I think before we end, the concluding remarks from our session chair, Dr. Khor.
Oh, back to me again. Well, I think we've all had I speak for everyone, we say we've really had a very educational, a very enjoyable session. 2 excellent talks, a terrific discussion, many points covered. And I trust that each of us has learned. I've certainly learned a lot, and I thank Adeel for putting this together with Pentax Medical, and you know, I look forward to more of these in the future. Actually, we have another one coming, don't we, Adeel?
Yes, we will plan. And I want to thank all our distinguished faculties. And in Asia, there are centers who are considered as center of excellence for advanced endoscopy training. They have a fellowship program and interventional endoscopy. And we are very honored that we have the faculties from the two distinguished centers from Singapore and Thailand. And again, I want to thank, in the end, the Pentax Medical, Asia Pacific, India, Pakistan, all coordinating and organizing this wonderful event. And we will come up with another session with exciting talks and important discussions on EUS. Again, thank you all, Dr. Khor, Dr. Damien, and Dr. Pradermchai.
Okay. Thank you.
Thank you.
Thank you.
Thank
Have
you,
a nice
and good evening and good night.
Good night.
Good night. Good night.
So good night, everyone.
Bye.
Okay, bye-bye.
Bye-bye.